So hi everyone, I'm Gabriel Altit, I'm a neonatologist at the Children. Today we will be speaking about image optimization. We have the approval of the parents of Abby who accepted to be part of this project to show people how to optimize the acquisition of image at the time of ultrasound image acquisition. So first, what's very important, it's environment of baby. It needs to be calm, ideally with the least amount of light possible in the room. And ideally, baby should be in a calm situation. Obviously, Abby here is a bit closer to term, but when you have babies that are very tiny, you won't be able to open the incubator for a very long period of time. Babies may lose heat very quickly. They may be very fragile. So these has to be very targeted, focused, and planned ahead of time regarding the questions we would like to answer. Hello, honey. So for term babies, we tend to actually bundle them in a way that they feel a bit more reassured. So typically we'll have the arms with a little linen. Oops, I don't want to stop. And then we try to have them along the side of their body and a bit tucked in like this. And then we actually put another linen like this to really make sure they are comfortable with the chest open. And for heart or chest ultrasound, we tend to have the electrodes kind of really spaced out to avoid having them in the middle of the way during the ultrasound. We use single pack gels that are warmed, so we have something that is comfortable for baby. And we also put classical music actually in our protocol of doing echoes here. So I will put classical music, and then the last thing I do is clean my hands, obviously, because I don't want to touch baby with hands that are not clean. So I'm gonna go into my peaceful piano and we're gonna start the music. So we're gonna clean hands. So when I acquire the images, we have different probes, and for cardiac we tend to use phase array probes. And as you can see on this particular machine, this one is a bit, there we go. We always have our probes cleaned between subjects because we want to make sure we don't transmit any infections. Smaller probes tend to have higher frequency, which means they have less capacity to go deep, so they're more superficial, but they give you better resolution. And bigger probes will typically be used more for the young pediatric / term infant at times. They have lower frequencies, so they can go with more penetration, but you lose in resolution. So actually we'll start with my smaller probe, and then we will start acquiring images. And various protocols of echo scans will have different sequences. The importance is that you're systematic and that you obtain the information of interest. So I'm going to go and get my images. For the purpose of the echoes, our machine is ECG gated, so we're able to capture the images of interest. Here I'm going to show a parasternal view, and then our fellow Pacini will continue the scan. So we can come closer to the screen. Basically what's important is that we narrow the sector along the structure of interest as much as possible, okay? And then when we capture the image, that we have our focus. If you have a machine that's focused, that really is aligned with the actual structure of interest. So for example, let's say I'm interested in looking at the aortic valve. Here I'm zooming on the aortic valve to see its opening and closing. You can see that the hertz is much increased, which means that the frame rate is increased and that my focus is really along the actual aortic valve. When I'm looking at color, I want to make sure to avoid as much as aliasing as possible. So here I'm going to actually increase my velocity filter because I know it's a high-speed arterial structure to see the blood flow and make sure there's no signs of obstruction. When looking at evaluations like M mode, before I continue, here I can see the stomach. I want to avoid having too much less of acoustic power. So sometimes you even need to do a bit more of adjustments of your depth. Okay, so here, for example, I would be happy about my parasternal view. Let's say you're putting M mode. You want to make sure that your M mode is most aligned with the structure of interest. So here, if I'm doing an LA on aorta M mode, I want to make sure that actually my line of interrogation has the least amount of angle and that I'm able to see my aortic valve closure. Same thing when I'm doing an M mode at the tip of the mitral valve. I want to make sure that actually I have the least amount of angulation and that I'm able to also capture part of the RV body. Now I'm going to look at the pulmonary valve. So you can see that ideally I would want to take a zoom of the valve in order to measure his diameter. So sometimes you have to adjust the probe position, go back to 2D, and sometimes the view, the best view is, and sometimes you have to pause for baby. So here now, I have a better place where I can see my pulmonary valve. And I see it in zoom, and I'm able to put color and then see if there's any signs of acceleration. Sometimes the view has to, I just want to see here. So here you can see I'm more in the parasternal short axis. Here I'm doing a CW, which is aligned with the valve. And there's a bit of acceleration at 18 of gradient. And sometimes it's actually in the apical views that you would see more the pulmonary valve. Here I'm looking more at my branch pulmonary arteries, so I will adjust my focus, decrease my sector in order to really concentrate on them. So I can see the right pulmonary artery, and I can see a bit of the left pulmonary artery. And we can even obtain velocities, so like pulse wave Doppler. And CW to make sure there's no sign of obstruction, and ideally you want to be in line with your artery. So same thing, I can do a CW in line of my RPA and then a PW. Okay. So now I'm in short axis, which is a good view to observe the septal deformation and make sure you have good function from the apex to the base of the heart. I'm gonna increase my sector this time and then look at papillary muscle area. Looks very round, circular. And I go down up to the apex. The septal curve usually is being assessed at the mid-papillary level, which is in this area, where I can see my two papillary muscle here, and it's at the peak of systole. So slowing down, the peak of systole is here, and you can see that it's very round, so I can unfreeze and get my loop. Same thing, we're often very well aligned here in order to get the M mode at the tip of the mitral valve. So here you can see that I'm able to obtain an M mode in order to calculate the shortening fraction if needed, as well as some of the metrics of LV mass. I can also see my pulmonary valve here, and I see there's a bit of acceleration for this particular pulmonary valve. So we'll obtain a CW to get a gradient, 21 millimeters of mercury, as well as a zoom. And we see the opening of the valve here and the closing, which is here. And I obtain this loop. The PDA view is close to here. It's often at the crossing of the aorta and the pulmonary artery. So this is the crossing of the pulmonary artery and aorta, where you have the pulmonary artery here and then the descending aorta here. And we can see that there's no connection in between for this particular patient. So no PDA. Okay. In this view, we can often also see the arch to make sure that we don't have any signs of obstruction at the isthmus level. Which is here. So to optimize, I decrease my sector. And here we can see kind of the sugarcane arch and the branching of the neck vessels. We can also make sure there's no signs of obstruction at the arch level. And then we can take an ascending arch Doppler. And we can do also a CW to make sure there's no obstruction or sign of obstruction here. As well as a descending aorta Doppler, which you're very well aligned, especially if there was a duct and you wanted to make sure there was no signs of retrograde flow in the descending aorta. So here we see there is no retrograde flow. Okay, so that's for the arch. We can also use this view to sometimes see the coronary, which we see some coronaries here, but that's really not focused, so I'm not gonna go there. We're gonna do an apical view. So for the apex, before I go there, for short axis in babies, I often see people go here, okay? Where it's very easy to actually flatten the septum because you're actually angulated. In babies, the short axis is much higher. So see the difference? Where now I can see that my LV is very circular. So you really need to make sure that you're not foreshortening your left ventricle, because then you're gonna have the impression that it actually looks very flat. So here I can make my LV look flat. And one of the tricks is that if you see atrium, you're way too low. Like here I see my full RV almost. So that would not be good. For the apical view, it says it. So it's the apex. It's like kind of the anatomical view of the heart. So here we see, first of all, posteriorly the coronary sinus draining into the right atrium. And then as you go anteriorly, ideally you want to see all the wall of your left ventricle. So you want to see the septal wall and the lateral wall. You want to see your mitral valve, and you want to see your apex, which is one of the most contractile area of the heart, okay? There's different way that you can improve resolution or optimize. Right now I'm on presets that are called resolution. I can go in general or penetration, which are actually changing the frequency of the probe. So for this machine, they are here. You can use something called harmonics imaging, which you can see here changes a lot the gray and actually increases the spontaneous contrast, which is something that personally I don't like. And you can also change things like, for example, your gray map and go to sepia or rainbow if you want. But we tend to go in black and white in our protocol. So I'll change probe to just give a sense of kind of images that we see. And then we'll give you other options of image optimization. So here I'm going to take the S9 probe, which, as we know, we're going to lose a bit of resolution, but go a bit deeper in penetration. So first I'm going to look at my LV, and we can see that here the wall is a bit lost with this probe compared to the previous probe. So sometimes you have to readjust yourself to really see the entire wall of your left ventricle. When looking at color, you want to see the flow through valves. So you want to make sure that you want to adjust your color without losing too much of the frequency. So if you increase too much your color box, you decrease your frame rate, versus if you narrow your color box, you're gonna have a better frame rate for image acquisition. So here we're looking at the inflow of the mitral valve. I can look at the velocity of which they occur. Sometimes in some babies, they have very fast heart rate, so you actually need to really have like the maximum speed width. But in some babies, like let's say you're concerned about tamponade, you might want to actually compress to see the variation with the breathing, which is one of the techniques to assess signs of tamponades. Whenever you're doing Dopplers, you have to be in line with the structure of interest. So you can see here that I'm really at the inflow of my mitral valve. If I was interested in my RV, I would want to bring my RV more in face of my probe in order to get the same effect of my RV and get the best tracing to see the E and the A waves, which is the early phase of filling and then the atrial contraction. Same thing for M mode of the TAPSI. So if I do a TAPSI, I want to make sure that I am aligned with the attachment of the tricuspid valve to the RV wall. And I want to make sure that actually this line crosses through the apex of the RV. If not, if you're too like this, you're actually not in line with the apex, and that's not how the measurement has been validated. It's been validated with the attachment of the valve. And what we're measuring the actual movement of the valve throughout the cardiac cycle. So if I show you how we would do it, we would actually measure the TAPSI. Oops, that's not what I want. TAPSI, tools. Let me acquire this and take it again. So let's say I'm here, measure, there you go, TAPSI. So the TAPSI is really from here to, you follow your line. So if I follow this line of the M mode, which is the tricuspid valve attachment, I get 1.16 centimeter, which is completely normal for a term infant. The other way to optimize like a TAPSI are by adding things such as TDIs at the same time, which allows you to map out the actual time periods. So we know that, for example, during the red portion, the contraction is towards your probe, so it's the entire systolic phase. So we know that systole is stopping here, and it's actually starting here. So it's a way to optimize if you're unsure about the time period. Zoom sometimes allows you to really put focus on the structure. So here I'm putting a focus on my right ventricle. I'm able to add color to it, and I'm able to actually obtain CW. CW has also, it's the capacity to obtain velocity throughout the line of interrogation. Images can be influenced by various factors. For example, you can influence your image by really adjusting your zone of interrogation. So here I'm moving my actual map of interrogation. The other thing that you can do is change your gain. So for example, here this is something that has way too much gain, and this is something that has way too low gain. And the gain will often appear on the machine here, and the gain is actually the amplification of the signal of ultrasound. So as the same way I can put increased gain on 2D or B mode, I can increase my gain also on the color. So here I'm increasing a lot the gain of the color, amplifying the signal. I can also change the velocity filter to filter some of the lower speed, or have, showcase the lower speeds, which in this case provides me a lot of aliasing for this particular subject. So typically in pulmonary veins, we do like to have lower velocity, so we're able to visualize these pulmonary veins. So example here where I see a pulmonary vein here that I'm able to image. And then same thing for the pulmonary vein that I see here, which is this red, so it's the right upper pulmonary vein. You have to make sure to never foreshorten your LV when you're obtaining a 4-chamber. When you're obtaining tissue Doppler imaging, if you're a unit that does this, you want to make sure that you don't put too much gain on your TDI. So that's an example where I decrease the gain on the TDI so it doesn't amplify the signal. You want to make sure that you're aligned with the structure and you're just under the actual attachment of the valves so you can see the motion during the different phases of the cardiac cycle. When obtaining TR, so that's one thing that's quite important to mention. So tricuspid regurgitant is a measure that we're interested if we're looking for pulmonary hypertension. So in this particular patient, I'm getting a bit of artifacts. So first I want to try to locate the zone of my TR and then be in line with the TR in order to be as much as possible not underestimating the actual velocity of it. So here you can see that I'm first localizing the TR, and once I'm on it, I'm actually trying to get as much in line as possible. So I sometimes have to adjust myself. So we're getting 15, but we're not getting a full curve. So sometimes you have to really work your TR skills to get a full curve. So I'm at 26, but we know this baby has also some degree of pulmonary valve acceleration, which is not clinically significant. So I don't think we're gonna get a better tracing of TR. So sometimes you do have to change the angulation of your probe in order to be the best aligned if you need to obtain a certain signal. I think I was better aligned before. Last thing, so let's say you're obtaining a cardiac output estimate. So this is, for example, the LV. So you want to first visualize your outflow tract and make sure there's no signs of obstruction. And then ideally, you need to be the least angle from your actual outflow tract when you're getting the estimate. The estimate also has to be make sure there's no VSD. No signs of VSD. Okay. So here, I'm not satisfied. There you go. So I want to be at the LVOT zone. Now I'm happy with my curve where I see nicely that I would be able to actually trace the VTI of interest. So I would do a trace option and oops. So trace. And then really you trace your actual area under the curve. And it provides you with a stroke distance estimate that you can plug into some of the equation to estimate LVO. Okay, so that's for the 4-chamber. We typically do also an apical view, and we do sometimes do the cerebral vascular ultrasounds. So I'll show first the cerebral because that tends to get babies less fussy. So you can obtain transcranial approach, which is typically on the side of the head, where if you put color, you're going to see your middle cerebral artery, which appears here, and you see your circle of Willis, which appears here. So, and typically your oh, I'm sorry, baby. here. So you're often in line with the MCA that you're able to get pulse wave Dopplers, and you're able to see the full contour of the actual vessel. So that's one approach to get the MCA flow. You can also get ACA flow from the sagittal view. So here, this is the anterior cerebral artery, where you can get the flow from the anterior cerebral artery. And then same thing, you can obtain the view from the coronal images, where you can actually obtain the circle of Willis, which is this thing here, and you see the MCA flow inside the brain here. So it's another way of getting the MCA flow, which in this case, I had better angulation from the transcranial approach. Here. There you go. Okay. So we'll finish with a subcostal, which is the area that they don't tend to like so much. So subcostal is particularly important for visualization of the interatrial septum. So we often use the liver, and so you can see first I'm gonna narrow my sector, and I use the liver in order to improve my echogenicity. And so you can actually use that to color compare, which does decrease your frame rate, so you have to be careful. And so here now you're going to be able to first see the IVC connecting to the right atrium. You see the SVC. I'm going to acquire this, give baby a little break. And then we saw that there was a little PFO. Okay, baby. Oh, there you go. Perfect. So here we see the crossing of the vessels. We're able to see our septum to make sure there's no signs of VSD, and I actually can see that there's a little PFO that is left to right, so a little flame. I can also turn to my short axis and then see the actual PFO here, which is a little red flame, and it's a really good view to be able to see also my IVC connecting to my right atrium. So it's a good view to see if there's SVC lines going into the right atrium, or in order to visualize the IVC, which is around here. So looks like almost a Mickey Mouse with the two ears here. And we're able to also sometimes appreciate the septal curve from this view. If you're well angulated, you're able to see that it looks circular, but in here I have a bit of a shift of my heart, so the short axis was a better view for that. It's also a view to see your descending aorta. So you're able to visualize the descending aorta, which flashes in red. And so you can also obtain Dopplers from the descending aorta here. So to see if there's retrograde flow or not in certain situations, like PDA, vein of Galen, things like that. And then sometimes you can even see the branching of your celiac and of your SMA. Oh, you moved. Just a little break the baby, which we saw here. This is the branching. So you can use this view to Doppler if you're interested in looking at the effect of certain shunts, for example, on the celiac artery or SMA. Okay. I think that's pretty much it for the image optimization. Pastini, can you come and get me just like a regular parasternal view? And we're gonna just show a few more things on the machine for image optimization. You can come, I'll show you on the screen. So yeah, perfect. So we can try to get just So a few things I want to mention. There's different sets of setups on your different machines for knobology. An example is the rate of compression, which allows you sometimes to better image, for example, coronaries or valves. So for example, if I'm interested in looking at valve leaflets, I can decrease my compression level, which will increase kind of the contrast of the leaflets or the structures that are very thin. Versus if you see I increase this compression level, here it becomes a bit more blurry. So that's one thing that is of interest for some of you. Different machine will have different AI ways of also optimizing the image. One of them for at least this particular machine is something called X resolution. So these different setups will also alter the way the machine is interpreting the image. So for example, in our protocol, we prefer the value of number 3, which provides us with a bit of a better image to our eyes. The other thing is that you can change your gray maps to give different sense of grays that the machine will be providing you. So you can see here I'm putting a gray map of 1, which is very different than when I actually use a gray map of 3. And it really depends what's also like your eyes prefers and the imaging protocols for your unit. You're gonna go in parasternal short axis now. So typically the short axis is 90 degrees from the long axis. And then maybe you can show us the pulmonary veins. So go closer to the branching of the RPA, LPA. Yeah. And then so typically for pulmonary veins, we like to see the mustache view. So go to your pulmonary arteries, like the pants views. And then, yes, perfect. So from the pants views, which are these two things, you can see that you can decrease your velocity filter, and then you can start seeing your veins appear. Here, exactly. So 1 and 2, 1 and 2. So these are the ones that are on the left side. And then we saw the one on, they're here. There's one here at least. Okay. So you can see that for this particular image, I had to decrease my Nyquist to provide me with more acquisition of something that's low velocity. We can also see coronary in this view. So it's good to take, zoom if you want to see coronary. And then here I'm going to decrease a bit my compression. Yeah, it's here, the coronaries, and we can even see the other one. That is the RCA. Not the best view for that. I think we're done for image optimization, and we'll do the rest together during the course.